Recording in progress.
Good evening and welcome everybody to our this cozy space. Nobi Pulmonology Masterclass. Madam के दिए दो. National Allergy Asthma Bronchitis Institute has been engaged in teaching, research, training, and clinic since its inception, and it was our birthday, 1st July 2008. Dr. B.C. Rai birthday, same birthday it was. Teaching has always been an integral part to our curriculum. Our previous classes were in great demand. Now we are online, and this is probably the 8th Nobi Pulmonology Masterclass. We are aware that there are a flurry of webinars around, but Nobi Pulmonology Masterclass is different. We want to emulate the standard classroom approach. What I want to hear if I were a student in this class. And today our topic is approach to pulmonary hypertension. It has a long story behind it. Actually, even when we were scheduling this class, there was difference of opinion among the faculty whether pulmonary hypertension should get a class before other topics, say oxygen therapy or respiratory failure. And I remember in our even postgraduate teaching, pulmonary hypertension was still a very much enigma in those days. So it was a long history. And fortunately, to elucidate it, we have two of the best speakers today on this topic, faculty Dr. Raja Dhar and Dr. B.V. Murali Mohan. Raja is Director and Head Pulmonology, CK Group of Hospitals, Kolkata, and he is also the Director, Research and Education, National Allergy Asthma Bronchitis Institute, Kolkata. He is Chair, Training and Education Initiative, Indian Chest Society, and multiple other laurels already at this age. 124 international and national publications, and many of us, we too, are together in those publications. And also we have Dr. Murali Mohan, Senior Consultant Pulmonologist and Academic Director of the Department of Internal Medicine at Narayan Hridayalaya, Bangalore. I know Murali Mohan probably for last 30 years, maybe Murali, or something more than that. He was earlier professor and head of Department of Medicine at Dr. B.R. Ambedkar Medical College, Bangalore. He is specially interested in the areas of obstructive airway disease, interstitial lung disease, and pulmonary hypertension. He has over 50 papers published in international and national journals, and he is a very speaker in demand at different national and international conferences. We have met at different parts of the country and different parts of the world at different conferences. So welcome Murali to this Nobi initiative. We are really honored to have you here. Raja is our own boy. I don't really praise him much in front of him. I do it in absence of him. So coming back to pulmonary hypertension, This is one of my favorite pictures. I used to teach pulmonary hypertension in those days with this picture. It was sailing on a ship, very smooth, serene, tranquil. Suddenly the storm comes and you are hit by a hidden rock just below the fine water. You didn't know that it was there. So that was pulmonary hypertension when we used to know about it. Uncommon, diagnosis was difficult, and as diagnosis was difficult, it was very difficult to even suspect. So over 30 years, we knew when and how to suspect pulmonary hypertension. Fortunately, echocardiography has revolutionized our concept, and we have started to look back again, say for radiology, how to look for pulmonary hypertension in chest X-ray, how to look for pulmonary hypertension in CT, then echocardiography, and fortunately, new generation pulmonologists should all be abreast with echocardiography and probably with cardiac catheterization as well. It is primarily a pulmonologist's job. It should not be left in the hands of others. So this is pulmonary hypertension. Suspicion that we have understood over 30 years, that is the clue, detection, evaluation, and management. And of course, it includes the groups, WHO groups 1, 2, 3, 4, and also functional classification. And then the journey over the years from single drug therapy to combination therapy. Actually, to start with, we had only oxygen. We thought oxygen is the best drug for, because we thought always about lung diseases, the hypoxia, and so oxygen is the preventer of pulmonary hypertension. And ultimately, now we are here on a personalized approach to management of pulmonary hypertension. We have two parts. The first part is the diagnostic part, will be dealt by Dr. Rajadhar, and the later part, management part, will be dealt by Dr. B.V. Murali Mohan. Actually, both know too much of it. They wanted to make it a full lecture class. We insisted, no, this is standard classroom approach. We have to complete in one class. At the best, you can get 30 minutes each. Fortunately, they have agreed. I am really pleased with that. And now, Dr. Rajadhar for the diagnostic part on approach to pulmonary hypertension. Dr. Rajadhar, please.
Hello, friends. My name is Dr. Rajadhar, and I'm here to talk to you for the NOBI Masterclass on pulmonary hypertension. We're going to do this talk in two parts. I'm going to talk about the classification and then the diagnosis of pulmonary hypertension. And then Dr. Murali Mohan will take you through the management, and we'll have a panel discussion thereafter. So my ambit today is to start off with the classification. And in the classification, I start off with the 2015 European Respiratory Society, Cardiology Society guidance for the diagnosis and treatment of pulmonary hypertension. Things have changed a little bit since the time. We've also got guidance from 2019, but I'll come back to that in a few moments. So by the 2015 guidance, the definition of pulmonary hypertension is pulmonary artery pressure of more than 25 millimeters of mercury on a right heart catheter. And this is classic of all groups of pulmonary hypertension. And again, I'll discuss the groups in a few moments. So I told you things have changed since then, and things have changed on the 6th World Symposium on Pulmonary Hypertension. So let's see what has actually changed in the definition. Data which has been accumulated on the basis of two large database papers, one from the ERJ in 2009 and the other from the Blue Journal in 2018, suggests that in normal healthy individuals, the mean pulmonary artery pressure in the resting state is 14 millimeters of mercury plus minus 3 millimeters of mercury. I want you to remember this because this is important for your exams going forward. So 14 millimeters of mercury plus minus 3 millimeters of mercury is the normal mean pulmonary artery pressure at rest. Hence, if you talk about 20 millimeters of mercury pulmonary artery pressure, that's 2 standard deviations above the mean pulmonary artery pressure of 14 millimeters of mercury. And hence, 20 millimeters of mercury, by that argument, should be considered as the upper limit of normalcy. There are certain conditions, lung disease, for instance, so COPD, interstitial lung disease, etc., left heart disease, etc., and mixed causes for pulmonary hypertension, where a mean pulmonary artery pressure of more than 20 millimeters of mercury is associated with increased mortality. And I'll show you data to this effect. Decreasing pulmonary artery pressure, however, in these groups of patients does not seem to impact mortality. So medications to reduce pulmonary artery pressure does not seem to impact mortality in this group of patients. Hence, data that mean pulmonary artery pressure of 21 to 24 millimeters of mercury, which is within the ambit of the new definition, alone should not be taken as proof of pulmonary hypertension because there are other causes which can contribute to this. Other causes as an increased cardiac output, other causes as an increase in pulmonary artery wedge pressure. So along with mean pulmonary artery pressure above 20 millimeters of mercury, hence between 21 and 24, along with a pulmonary vascular resistance of more than 3 Wood unit, together would define pulmonary hypertension by the current criteria in 2019. So I'll repeat that again because it's worth remembering. Mean pulmonary artery pressure between 21 to 24 millimeters of mercury plus a pulmonary vascular resistance more than 3 Wood unit would increased pulmonary artery pressures or pulmonary hypertension by the current definition. Hence, a motion has been started to lower the cutoff of defining pulmonary hypertension from 25 millimeters of mercury to 20 millimeters of mercury. However, till date, there's not enough data to say that using drugs in this category of patients, hence the lower pulmonary artery pressure that we have just quoted, would actually make a difference to the natural course of the disease process. Hence, what we need today are studies with this mean pulmonary artery pressure, so the pulmonary artery pressure of more than 20, plus a PVR of more than 3 Wood unit, use drugs which lower pulmonary artery pressure in group 1 pulmonary hypertension, in group 4 pulmonary hypertension, etc., and see whether that changes the natural course of the disease. For the purposes of my discussion today, for most of the time, I will be going according to the 2015 guidance, which I quoted first, because that's the area in which the data is available. The New York Heart Classification classifies the amount of breathlessness that a patient has. Why is the New York Heart Association classification functional class so important? It's important because it's directly correlated with survival. So NYHA class 1 and class 2 has a much better mean survival as compared to NYHA 3 and 4. The problem with pulmonary hypertension, pulmonary arterial hypertension, is that there's very few patients who actually get diagnosed in NYHA 1 and 2. More than 80% NYHA 3 or 5 by the time the disease is diagnosed. And this is seen from this Blue Journal paper, which dates back to more than 15 years. So you saw the survival was much poorer in class 3 and class 4, which is why outcomes in pulmonary hypertension are as poor as they are today. So these are a description of the clinical presentation of pulmonary hypertension. And you can see that the early symptoms are non-existent. Hence, diagnosis, like we said, is late. The first signs are of breathlessness. So progressive dyspnea on exertion is the presenting symptom in more than 90% of cases. And in the remainder, there's accompanying exhaustion, fatigue, etc. By the time you reach NYHA 3 and 4, there's chest pain, and the chest pain is similar to what you get in coronary artery disease. There's syncope. The syncope is mostly exercise-induced. And I want you to remember that because that's the reason why stress echocardiography or exercise echocardiography is something which is not advocated in patients with pulmonary hypertension, even though it's a marker of disease process. Because exercise induces syncope in patients who progress, who are NYHA 3 and 4. And the late signs are those of right heart failure. So edema, ascites, ankle swelling, etc. All of these equate to right heart failure and are markers of late stage disease. So I want you to remember this: early, first signs, progression, and late, because this is what you need to remember as far as your exams are concerned for clinical presentation. The signs of pulmonary hypertension are central or peripheral cyanosis. Often you have mixed cyanosis. However, cyanosis is difficult to pick up in our population and often is similar to normal skin color in our population. You know this from before. The fingers are often cold and cyanotic, and often this tightening of the skin analogous to what you get in scleroderma. There's sometimes facial cyanosis. When I say facial cyanosis, it's more in the snout area where my hand is just now. So facial cyanosis, similar to that you get to what you see in mitral stenosis. There are signs of right ventricular hypertrophy, the signs of right ventricular enlargement in the way of left parasternal pulsations. There's a loud P2, and there is a systolic murmur in the left parasternal area, which is indicative of the TR jet, which happens in pulmonary hypertension. And there are enlarged neck veins with pulsation, edema, and ascites we've spoken about already. So that's signs of pulmonary hypertension. What about basic investigations? So the X-ray shows the typical cardiac silhouette where the pulmonary segment, where my marker is at the moment, my cursor is at the moment, that's where the pulmonary artery segment gets bulged out. And often with the aortic arch and then the pulmonary segment, there's a straightening of the left border of the heart. So that's what's meant by a typical cardiac silhouette. I'm not sure you can see this properly, but you would have seen ECGs of people with pulmonary hypertension. There's a prominent P wave. There's a right axis deviation, which is indicative of right ventricular hypertrophy. There's right bundle branch block, and there are non-specific STT changes. However, remember, a normal ECG in no way excludes a diagnosis of pulmonary hypertension and is present in about 15% of the population. The lung function tests are mildly obstructive or restrictive in pattern. The DLC is normal or reduced, especially in patients with connective tissue disease, especially in diseases like scleroderma. And these patients on an ABG often have a low PaCO2. So X-ray, ECG, and PFT, and you can see none of these investigations actually diagnose pulmonary hypertension. They might contribute to the diagnosis. So before we go to further investigations, let's look at the clinical classification. So this is the clinical classification as from the 2015 guidance. And I'll come to 2019 in a minute. But you can see that there are 5 classes of pulmonary hypertension. There's pulmonary arterial hypertension. And in this category of disease, there's idiopathic, heritable, there's drugs, and there's a whole host of diseases which behave like idiopathic disease, like connective tissue diseases, HIV infections, portal hypertension, etc. So that's class 1 pulmonary arterial hypertension. Class 2, so after that is 1 prime disease, not class 2, but 1 prime disease, which is pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis, what's also called PCH. These are the genetic variants of the disease. The heritable variety has certain mutations which are on that slide, which you need to remember for your exams. This is also the idiopathic variety, and again, HIV, CTD, etc., all fall in this subcategory of disease. So that's 1 prime disease, pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis. Class 2 disease is pulmonary hypertension due to left heart disease. And here you have left ventricular systolic dysfunction, diastolic dysfunction, valvular disease, etc. So left heart disease resulting in pulmonary hypertension is class 2 pulmonary hypertension. You then have class 3 pulmonary hypertension. That's where the pulmonologists come in. That's pulmonary hypertension due to lung disease and or hypoxia. And here, the important lung diseases, COPD, interstitial lung disease, pulmonary disease, which causes a mixed restrictive and obstructive pattern, sleep disordered breathing, etc., all come into the ambit of class 3. So class 3 is pulmonary hypertension related to lung disease. Class 4 is chronic thromboembolic pulmonary hypertension and other pulmonary artery obstruction. And the major player here, the vast majority of patients are chronic thromboembolic pulmonary hypertension. And then there are other causes of pulmonary artery obstruction. Class 5 is pulmonary hypertension with unclear or multifactorial mechanisms. And here you have diseases like hematological disorders, chronic hemolytic anemia, myeloproliferative disease, splenectomy, etc. You've got systemic diseases like sarcoid, metabolic diseases, and so on and so forth. So multifactorial causation. These boxes are important, these classes are important because the way you treat the disease and the prognostication to an extent depends on which group you are in. However, there are fallacies to the classification, and let me show you one here. So let's take the example of a case, one you might encounter any day in your clinic. So we are talking about a 65-year-old male who's got hypertension and atrial fibrillation. So just this bit of history, the fact that he's got atrial fibrillation, heart disease, puts you into category 2 if you were to put the patient into the classification of pulmonary hypertension. This patient is also a smoker, has got mild COPD. So that puts you into class 3, which is pulmonary hypertension due to lung disease. This patient also has chronic myeloid leukemia, which is under control, but the chronic myeloid leukemia puts you into class 5, which has got hematological disorders in it. The same patient for the CML gets treated with dasatinib. So dasatinib is a drug which causes pulmonary hypertension and is in the drugs and toxins part of class 1 of pulmonary hypertension. So that's class 1. And this patient also has some degree of VQ mismatch on a VQ scan, which puts you into class 4 because there's a possibility of chronic thromboembolic pulmonary hypertension here. So short history, a 5-line history can put you into various categories. And hence what we're trying to show you is that these are not watertight boxes. They're classes, but there's a lot of overlap when patients come to you on a day-to-day basis for the class in which the pulmonary hypertension belongs. The reason this is important is because when you look at treatment, is specific treatment indicated? Like I told you before, in class 1 and class 4, there's specific treatment which is indicated. In class 1 prime, you need to be cautious about treatment. In class 2 and in class 3, the drugs can actually be potentially dangerous. It might increase mortality. And in class 5, there's hardly any data, so we don't know whether we should give drugs or not. So this patient The classification is important. The driver for pulmonary hypertension is important because you need to decide whether to give pulmonary hypertension specific treatment in these patients or not. What's changed in 2019, I'm sorry. So in 2019, there are two diseases. One is sarcoid and the other is lymphangioliomyomatosis. And the general thinking, I won't drag you through this because I'm sure Dr. Murli Mohan will cover this in detail later on. But in sarcoid and in lymphangioliomyomatosis, both of which are essentially parenchymal diseases of the lung disease causing pulmonary hypertension, we argue, or the group argues, that the patient should be in group 3, which is pulmonary hypertension due to lung disease, rather than being in group 5. Hence, you can see the revised classification. There's a question mark as to whether LAM and sarcoid should be in group 3 pulmonary hypertension rather than group 5 pulmonary hypertension. There's also a subclass that's been added in the updated classification in 2019, which talks about vasoreactivity to calcium channel blockers. That's been added in. So PAH with vasoreactivity, which is calcium channel blockers, essentially acute and long-term, is a subgroup that's been added into group 1 of pulmonary hypertension. And those are the changes. And I'm sure you will hear more about this from Dr. Murli Mohan. So we go by the 2015 guidance, like we said, and we're still looking at a pulmonary artery pressure of more than equal to 25 on a right heart catheterization. So the definition actually acknowledges that there's need for right heart catheter before the introduction of any specific pulmonary hypertension treatment. The right heart catheterization performance is difficult. It's the challenge, especially in countries like India. And hence, the performance of this is unlikely to benefit in patients who belong to class 2, class 3, or class 5, unless you're going to prescribe pH-specific treatment, modifying treatment, which you would do in a minority of cases. So essentially, a large majority of patients in class 2, class 3, and class 5 do not require a right heart catheterization. We need to accept that there will be overlap between pH groups, and there are multifactorial causes of pH, like we saw in the case a little while ago. And it's important to remember that in pulmonary hypertension, it's critical to recognize which patients need to be referred to a tertiary referral center. We talked a little while ago about the importance of the NYHA classes, the fact that having pulmonary hypertension automatically puts you into high-risk group, and the next couple of slides establishes that. So this is looking at cohorts of patients with mild pulmonary hypertension and looking at hospitalization and survival. Now I want you to look at my cursor here. If you look at hospitalization in patients with pulmonary hypertension, the number of patients who get hospitalized is far greater as compared to patients with mild COPD who do not have hospitalization. And the same for survival. If you have a mean pulmonary artery pressure of less than 25 millimeters of mercury, you survive much better. Your mortality is lesser as compared to people who have a pulmonary artery pressure of more than 25 millimeters of mercury. The disease changes. So COPD changes to pulmonary fibrosis on this slide, and the mean pulmonary artery pressure is lower as a cutoff here. Less than 17 and more than 17 is what was looked at in this particular study. However, the bottom line doesn't change. Survival is much better with a mean pulmonary artery pressure of less than 17 millimeters of mercury as compared to patients who have a mean pulmonary artery pressure of more than 17 millimeters of mercury. So we go on with diagnostic investigations. We've done chest X-ray ECG and we come now to echocardiogram. So let's have a look at how echocardiogram is important in the diagnosis of pulmonary hypertension. My understanding of pulmonary hypertension is limited. However, I'll take you through things I look at in my day-to-day practice. And this is what I believe is important for you from an exam perspective. So echocardiogram should be performed when pulmonary hypertension is suspected. However, it's not enough to support pH-specific treatment decisions. We have said this already. cardiac catheterization needs to be done in these cases. Echo is used to assign a level of probability of pulmonary hypertension, whereas cardiac catheterization tells you what the exact levels are. And probability of pulmonary hypertension should not be defined by a cutoff value of peak TR gradient, and I'll show you why that is in a moment. However, this slide and the next one shows you the limitations of echocardiography. This looks at the pulmonary artery pressure as measured by echocardiography, so echo Doppler study versus a right heart catheterization. And you can see the scatter of the dots and the triangles, which shows that the pulmonary artery systolic pressure was different by more than 10 millimeters of mercury when measured by echo versus right heart catheterization in about 50% of patients. So in more than 50% or in about 50%, 1 out of 2 patients, your right heart catheter pulmonary artery pressure would be 10 millimeters different as compared to the pulmonary artery pressure, which has been measured by echocardiography. The same happens, without dragging you through the slide, on estimation of CVP versus right atrial pressure. Again, CVP measurement and right atrial pressure measurements are inaccurate when you compare them with right heart catheter in estimating mean pulmonary artery pressure. Again, if you try and look at measurement of cardiac output on an echo Doppler and you look at right heart catheterization, again, you can see the scatter on there. Hence, the measurements vary even when you try and measure cardiac output as an estimate of mean pulmonary artery pressure. So this is what the guidelines tell you. The guidelines tell you that if the peak tricuspid regurgitation velocity is less than 2.8, so there's essentially no TR gradient, there's no regurgitation. In the absence of PH signs, the echocardiographic probability of pulmonary hypertension is very low. So essentially, echocardiography will exclude that the patient might have pulmonary hypertension. I want you to look at the red at the bottom. If your TR gradient is more than 2.8, so between 2.9 and 3.4, and you have pulmonary hypertension signs, or your TR gradient is more than 3.4, so there's a large gradient, large regurg, even in the absence of PH signs, echocardiography can tell you almost definitely that there is pulmonary hypertension. However, the difficulty is with the yellow zone. So in the yellow zone, if you have a tricuspid regurg velocity of less than 2.8 or not measurable, and there are presence of other echo signs of pulmonary hypertension, or your TR gradient is between 2.9 and 3.4, in the absence of pulmonary hypertension symptoms, these are intermediate. And if you have to give disease-modifying drugs, you need to do a right heart catheterization. What are the other echocardiographic signs suggesting pulmonary hypertension? And I want you to look at the 3 on the top: the ventricle, the pulmonary artery, the inferior vena cava, and the right atrium. So let's look at the dominance pattern of the ventricles. The right ventricle dominates over the left ventricle in patients with pulmonary hypertension. What that means in echocardiographic terms is that the right ventricle by left ventricle basal diameter ratio is more than 1. There's flattening of the interventricular septum in patients with pulmonary hypertension. What about the pulmonary artery? The pulmonary artery tells you about the RV pulmonary artery coupling. So the right ventricular outflow Doppler acceleration time of less than 105 meters per second and or a mid-systolic notching indicates an RV by PA coupling. The early diastolic pulmonary regurg velocity should be high, more than 2.2, and the PA diameter would be more than 25 millimeters. Third, in the late stage, there's RV failure. And here the IVC diameter is more than 2.1 centimeters to 221 millimeters with decreased inspiratory collapse, either on sniff or on quiet inspiration. And the right atrial area is more than 18 centimeters. So echocardiographic sign, 3 parameters: RV over LV domination, RV by PA coupling, and RV failure. And the features on this slide are what you need to remember for your exams in doing echocardiography in these patients. So the diagnostic management according to echocardiographic probability of PH in patients with symptoms are on this particular slide. So if you have an echocardiographic probability of PH which is low, an alternative diagnosis should be considered. If it's intermediate, do consider an alternative diagnosis. Make sure you do an echo follow-up in about 6 months to a year, and further investigations of pulmonary hypertension should be considered. If the echocardiographic recommendation is high, if the echocardiographic probability is high, further investigations of PH, including right heart catheterization in the right scenario, is recommended. And you can see that in this category, the category where the prediction is high on echo, the investigations and right heart catheterization has the strongest evidence. Let's go to the next slide. That diagnostic algorithm for pulmonary hypertension, again, from the guidelines is in front of you. So if symptoms and signs or history is suggestive of pulmonary hypertension, you look at the echocardiographic probability of pulmonary hypertension, which we have just discussed. If based on this, the possibility is low, it's easy, you consider other causes and a follow-up like we have recommended. If, however, echocardiographic probability is high or intermediate, you consider the various categories that we described in the classification, left heart disease, lung disease, etc., and you do investigations accordingly, the ECG, the lung function, the chest X-ray, the CT, ABG that we all talked about. If you manage to diagnose left heart disease or lung disease, then you go accordingly. However, if you do not manage to diagnose left heart disease or lung disease, then you do a VQ scan. And if the VQ scan shows mismatched perfusion defect, then you refer to a pulmonary hypertension center. If on trying to diagnose left heart disease or lung disease, you find signs of severe PH or RV dysfunction, again, you should refer to an expert center. So there you see what tells you echocardiographic probability, which is high or intermediate. You've seen this slide a little while ago, and I've just repeated it to reiterate the point that the echo findings are important. So you've got VQ, we reached the VQ scan, and if you find mismatched perfusion defect, we said you refer to a pulmonary hypertension center. The reason you do that is because this mismatch might be related to chronic thromboembolic pulmonary hypertension. And here you would need something like a CT pulmonary angiogram, a right heart catheterization, or in centers of reference, you might even get a pulmonary angiogram done. If you do not manage to refer to a pulmonary hypertension center, you would need to find a center which would do a right heart catheterization. If your mean pulmonary artery pressures are more than 25 millimeters of mercury, if the pulmonary artery wedge pressure is less than 15, and the PVR is more than 3 Woods unit, then it's likely that there's PH, and you go through the algorithm to look for causes of pulmonary hypertension in this case, the CTD, the drugs and toxins, the HIV, etc., are on that slide for you to see. If you find that the right heart cath does not show a mean pulmonary artery pressure of more than 25 and the other parameters outlined, then you need to consider other causes. So chronic thromboembolic pulmonary hypertension on one side, and on the other, a right heart catheter to look at pulmonary artery pressure and other causes of pulmonary hypertension. So these are recommendations for right heart catheter in pulmonary hypertension patients. And again, these are the 3 recommendations that I want you to remember. So recommended to confirm diagnosis of PH in group 1 to support treatment decisions. So all patients with group 1 should have a right heart cath in trying to decide about treatment. In patients with pulmonary hypertension, it's recommended to perform right heart cath in expert center because this is technically demanding and can be associated with complications. And right heart catheterization should be considered in any patient where you're going to assess treatment effect of drugs. The other areas where right heart catheter is recommended is in patients with congenital cardiac shunts to support decisions of correction, in patients with pulmonary hypertension due to left heart disease or due to lung disease where organ transplantation is considered, when measurement of pulmonary artery wedge pressure is unreliable, in left heart catheterization should be done. Right heart catheter should be considered in patients with suspected PH and left heart disease or lung disease, and right heart catheterization is indicated in patients with chronic thromboembolic pulmonary hypertension. Screening is by echo, and this tells you that resting echocardiography is recommended as a screening test in asymptomatic patients with systemic sclerosis, because in systemic sclerosis, the incidence of pulmonary hypertension is greater. Resting echocardiography is also recommended as a screening test in patients who carry the BMPR2 mutation or first-degree relatives of patients with hereditary pulmonary hypertension who are referred, or portopulmonary hypertension who are referred for liver transplantation. So that's a recommendation for pulmonary hypertension screening. These give you newer screening criteria for pulmonary hypertension. So the combined approach of using biomarkers, lung function tests, echocardiography should be considered to predict pulmonary hypertension in patients with systemic sclerosis. In patients with systemic sclerosis, and remember this is from 2015 guidelines, in line with what's been said in 2019, systemic sclerosis patients with mean pulmonary artery pressures of 21 to 24 millimeters of mercury should be closely monitored. So you saw the 2019 guidance. Maybe we extrapolate what we did in systemic sclerosis for other conditions also. So this shows you the algorithm for management in patients who have a perfusion defect on a VQ scan and for patients who don't. I won't drag you through this because this is similar to what I showed you in the other guidance a little while ago. This looks at diagnostic approach of chronic thromboembolic pulmonary hypertension. This is something Dr. Murli Mohan will speak to you about in detail, I'm sure. However, just to introduce the topic, if you have a VQ scan where there are indeterminate or multiple perfusion defects, further imaging, including a CT pulmonary angiogram, an MR angio, or a pulmonary angio should be done to try and show evidence of CTEPH. And there should be multidisciplinary discussion between a chest physician, a radiologist, and a surgeon. A surgeon, because pulmonary thromboendarterectomy is the treatment of choice here, and hence a discussion between these partners should be done to try and reach a treatment decision. This is just showing you some photos of perfusion scans in CTEPH, and you can see the clots in acute PE and the clots, the layering of clots on the arterial wall in patients who have chronic thromboembolic pulmonary hypertension. You see the mosaic perfusion defects in CTEPH on that scan. So the gray areas with my cursor and the black areas adjacent give rise to the mosaic perfusion that's been described. How to perform right heart catheter, I'll leave that out for the want of time. I've actually run out of time already. However, important to say that vasoreactivity testing should be done in pulmonary hypertension when you're doing a right heart catheter. And this is done to identify the 10% of patients who would respond to a calcium channel blocker. There is some thought process that this should be a part of the classification, which is why it's been now put into group 1. What needs to be used? Rapidly acting selective pulmonary vasodilators should be used. And you can see the names of drugs on there: epoprostenol, adenosine, nitric oxide, or iloprost are drugs which should be used to select for vasoreactivity. The importance of this is that patients who respond to long-term calcium channel blockers, who have a vasoreactivity test positive, and hence long-term response to calcium channel blockers, will have a far better cumulative survival as compared to people who do not respond to calcium channel blockers. And the definition of responder is the mean pulmonary artery pressure should drop by more than 10 millimeters of mercury from baseline to below 40 millimeters of mercury with a normal cardiac output. So mean pulmonary artery pressure dropped by more than 10 millimeters of mercury from baseline or to below 40 millimeters of mercury with a normal cardiac output. So that's the diagnostic algorithm that we spoke about. A history and signs, so symptoms and signs that we've spoken about, and echo to assess probability. If the echo is negative, you find other causes. If the echo shows high or intermediate, you go through the algorithm, and there are certain areas where you need to refer to an expert pulmonary hypertension center. So my concluding remarks is that echo should be performed when pulmonary hypertension is suspected. However, echo is not sufficient to support a treatment decision about PH, and cardiac catheterization is required in those cases. It's recommended, strongly recommended, that we in India build up centers where right heart catheterization is performed with some degree of regularity. Doing a one-off or a two-off cardiac catheterization a month will not build up enough expertise for us to give us answers and might result in adverse effect for the patients who are getting these done. Screening is recommended, but in a select few patients, especially asymptomatic populations who are at a higher risk of PH. And here we spoke about systemic sclerosis, we spoke about the BMPR2 mutation, etc. So these are populations that should be screened. The new diagnostic algorithm will help in a more systematic approach. I also showed you the 2019 guidance as a glimpse, and hence it might be going forward that the pulmonary artery pressures come down even further in defining pulmonary hypertension in our population of patients. I thank you very much for a patient listening, and I look forward to hearing Dr. Murli Mohan's talk on this particular topic.
So thanks, Raja. That was as lucid as possible, a difficult topic, particularly the approach, diagnostic approach. Now let us see what we have got from it. So number one, the definition. And the changing definition, previously it was 25 millimeter of mercury, come down to 21, but that does not mean that you have to start treatment at 21. You have to rather observe and evaluate. Number two, classifications we have gone, disease process, that is the heart disease and the lung disease. And if I remember our class days, the examiner will ask you, the first thing is, when do you suspect pulmonary hypertension? So suspecting pulmonary hypertension may be in a known setting. For example, any patient with PSS, progressive systemic sclerosis, should we look for pulmonary hypertension, whether there is any history in support of it or not. So any examinee having a case of PSS or say MCTD, mixed connective tissue disease, must look for evidences of pulmonary hypertension clinically first and then investigation wise. Unknown setting, it is very difficult, but still the examiner will ask you, what are the symptoms? This unexplained dyspnea, particularly dyspnea on exertion, which can be precipitated very well by doing a 6-minute walk test. And then the fatigue, the non-specific chest pain, and of course, the clinical examination. Now, in these days of investigation, sometimes students are at a loss when they are asked about the clinical features of pulmonary hypertension. Well, it would be very easy if you get some signs of right heart failure, dependent edema, interstitial liver, neck veins, but that is much late to come. So pulmonary hypertension, you have to locate it on the pulmonary area. That is the left side, second space, parasternal. And here you get the pulmonary second heart sound loud. There is a split, and it's a closed split. This is very important. For example, I will tell you, in ASD, you get a wide split. In pulmonary hypertension, it's a closed split. So loud second heart sound with a closed split, and of course, you can get a ejection systolic murmur. And then the right ventricular heave down below, you look for the right ventricular heave. And so examiner is happy now, he will give you the next. No, pulmonology exam will not give you the echo first. They will give you a chest X-ray. And you have to know how to suspect pulmonary hypertension in a straight X-ray chest PAV. Again, we don't see those plates nowadays. Previously, two plates were very competing with one another. One was a classical case of mitral stenosis. Sometimes in mitral stenosis, you don't see it because the left heart is enlarged. There is right ventricular enlargement, is a double contour, where you have to look for it. So only clue can be the pulmonary bay is not there, it is full. So usually the aorta, then down below, here the left ventricle, there is a bay here, that is the pulmonary bay. And that pulmonary bay, when it is filled up, this is indicative something is happening there, the left main trunk of the pulmonary artery. So pulmonary bay, and I remember those days. Another very common, I don't see them much now. This is atrial septal defect. Atrial septal defect, mitral stenosis, competing with each other. Both features of pulmonary hypertension, bay is filled up, but pulmonary hypertension, particularly mitral stenosis, there is distal pruning of the pulmonary vasculature, and atrial septal defect, you see the vascular plethora actually, which is very characteristic of atrial septal defect. So you have to look for, and then the measurement of the main trunk of the pulmonary artery, both in X-ray and in CT. You have to be abreast with these things when you are appearing in the exam. Then, of course, you can get the ECG, yes, the P pulmonary, the peak piece, and then you may get the RBBs, partial usually, and you can get the right ventricular hypertrophy. And then you can be eligible to get the echo. Echo is usually done by cardiologists, but the days are changing. I think practicing pulmonologists should have at least a grasp of echocardiography for the right heart. And even if the cardiologist does it, we always do it in a close collaboration. I always instruct them what to look for. And then they look for particular things, including pulmonary systolic pressure and pulmonary mean pressure. So this is the diagnostic part. Raja has done very well over it. Now we are moving to the management part. It is now to Dr. P.V. Murali Mohan for the next part. Dr. Murali Mohan, please.
I'm Dr. B.V. Murali Mohan. I'm a pulmonologist from the Narayana Health Mazumdar Shaw Medical Center in Bangalore. And it gives me great pleasure to be here with you all to talk about the management of pulmonary hypertension. Obviously, it's very difficult to follow a great speaker like Dr. Rajadhar, but I'm grateful to him for setting the stage for me by giving you an understanding of the approach to the diagnosis of pulmonary hypertension in all its different groups. I'm also grateful to Professor Ghoshal for inviting me to give this talk, and to NABI in general for this wonderful series of programs that they're talking. This is my conflict of interest statement, and I bring you greetings from the beautiful city of Bangalore, which you can see was even more beautiful during the lockdown. And of course, I bring you greetings from the Narayan Hridayalaya Mazumdar Shaw Medical Center, which is one of the major centers for the management of pulmonary hypertension, especially of chronic thromboembolic pulmonary hypertension. It's said that the pulmonary circulation lies in the territory between the cardiologist and the pulmonologist, but is understood by neither. So let's hope by the end of today, we have a better understanding of pulmonary hypertension. So what I plan to do is take you through a revision of the major groups and understand the treatment for pulmonary hypertension in each group, basically focusing only on group 1, pulmonary arterial hypertension, group 3, which is associated with lung disease, and group 4, which is chronic thromboembolic pulmonary hypertension. And why do I plan to take you through the main groups again? Because an understanding and remembering the main groups is the first step in the management, because the management is completely determined by which is the group of pulmonary hypertension the person belongs to and what is the underlying etiology. So group 1, as you know, is pulmonary arterial hypertension, where the disease is in the arteries itself. It used to be called primary pulmonary hypertension, but now we divide it between idiopathic pulmonary artery hypertension on the one hand and associated pulmonary hypertension on the other hand, both of which are pulmonary artery driven, but in associated, there is usually another cause which is recognized, unlike an idiopathic pulmonary hypertension. Group 2 is secondary to left heart disease, while group 3 is associated with lung disease or hypoxia due to any other cause. So the etiology there is hypoxia basically, or extensive involvement of the lungs vascular bed. Group 4 is due to pulmonary artery obstructions, for which the commonest is thromboembolic disease. In this case, we'll be talking about chronic thromboembolic pulmonary hypertension, but there can be other causes of pulmonary artery obstruction. And finally, when nothing fits into one of these groups neatly, or we recognize that there are multiple mechanisms operating, we usually will call it group 5 pulmonary hypertension. But these days, the tendency is to move it to one of the other groups when we recognize that that is the major cause of pulmonary hypertension. For example, sarcoid with extensive lung involvement would fall into group 3, though it may also involve the vascular system and may also involve the heart. But if it's the mainly lung involvement, then we will put it into group 3. You've already seen this, and this is the diagnostic algorithm. And the important thing is when there is a high echocardiographic probability of pulmonary hypertension, and Dr. Rajadhar has already told you about what this is, you fast track the patient to a PH center if there is a high or intermediate probability. If it's low, you start to recognize other causes. If it's not such a high-risk patient, you can always go through a VQ scan, screen for chronic thromboembolic pulmonary hypertension, look for heart disease and lung disease, and then, if there's neither of these, refer to a PH expert center. So that is the current algorithm for the management of pulmonary hypertension. So you assess the probability, identify the high-risk patients which you want to fast track to a good center because the mortality rate is very high in these patients. If not, you try and diagnose the main cause of pulmonary hypertension yourself. And then if that is ruled out, then you refer to a PH expert center to look for the rarer cause of pulmonary hypertension. So please remember these first 4 steps. And why do I keep emphasizing that the group identification of what is the cause of pulmonary hypertension is very important? Because survival in pulmonary hypertension depends on the cause. For instance, you can see in this from the ASPIRE registry, one of the large registries, and the Spanish registry, a smaller one-country registry, but still very important. You can see that pulmonary hypertension due to left heart disease has probably the best prognosis of all. CTEPH is managed well, it has good prognosis, whereas the kinds of pulmonary hypertension we see in lung disease has the worst prognosis of all. Group 1 pulmonary hypertension falling somewhere in between. Again, the same message coming out from the Spanish registry, where idiopathic pulmonary hypertension and CTEPH had very good prognosis, whereas other causes of group 1 hypertension had worse prognosis. For example, in portopulmonary hypertension, it was bad, and in pulmonary veno-occlusive disease, it was worst of all. So you must find out the underlying cause. So please remember the lessons Dr. Rajadhar has taught you, because that is very important from the point of view of deciding on the management pathway. The other very important thing you must do right in the beginning is to decide what is the functional class. This is very similar to what you studied in the first clinical year of your MBBS, where an NYHA class is identical to the WHO functional class of pulmonary hypertension. In functional class 1, there's no activity limitation. In functional class 2, there's slight activity limitation. In group 3 or class 3, there's marked limitation of activity. And in 4, even at rest, you have symptoms. So identical to the NYHA classification. Why is it important? Because the functional class determines the survival. People in functional class 2 have an excellent survival. You can see survival at 3 years is better than 80%. Functional class 4, practically 50% survival, 18 months. So median survival of 18 months in functional class 4 compares with an overall survival of greater than 80% with functional class 2. Very important you determine the functional class at the start and then follow them up over time to determine what is the functional class, the response to your treatment, and so on. Now we know that the 6-minute walk distance compares with the functional class very well. And you can see the difference. I don't need to take you through the details, but in comparison with controls, as the functional class got worse, the 6-minute walk distance came down, and therefore we use 6-minute walk distance as a surrogate of mortality. Most studies have been done in pulmonary artery hypertension, that is in group 1. So it's very important to recognize that PAH is very different from PAH of other causes. It's applied specifically to group 1, and only a minority of pulmonary hypertension is due to pulmonary arterial hypertension. So PH and PAH have different etiologies, different treatments, very different prognoses. And pulmonary vasoactive medications like sildenafil and riociguat and so on have been proven to be useful only in PAH group 1 and not in most other pulmonary hypertension. Now, a decade ago, idiopathic pulmonary artery hypertension, or as it was called then, primary pulmonary hypertension, was a dreaded disease. The quoted median survival, as I showed you earlier, of about 2.8 years across all groups. Now, the new pulmonary vasoactive medications have changed this very dismal scenario. So let's look at what these drugs are and how we use them. And this is what you can see. The survival has so significantly improved over time. So this survival curve shows you the NIH equation was applied in the 80s, and this was based on the survival curve then. The PCH equation, the red one, came in later, and the observed survival was very close to that. Okay, but over time, the French equation came later, and you can see that over time this has improved. Our observed survivals now are much better than those of those predicted by the French equation, or indeed by the old NIH equation. So things are getting better. So when you plan to treat a patient with pulmonary arterial hypertension group 1, please follow an integrated plan. This involves several steps, and it's important to go through each of these steps to assure your patients of the best outcomes. First of all, perform a thorough diagnostic evaluation, as Dr. Rajadhar has told you. Then consider which group the patient belongs to. So do the pH classification and assess all the comorbidities. Assess the risk profile, which I'll take you through, and always understand what are the patient's goals and preferences. And based on your understanding, as well as taking into account the patient's goals and preferences, you create an initial treatment strategy. Based on all this, you implement a proactive longitudinal follow-up care plan, because you need to be able to very quickly adjust the treatment, hike or reduce the treatment, depending on whether you've achieved your goals or whether you have not achieved your goals, or if the patient is having any problems with the drugs that you have used. Finally, have some clear metrics, be able to measure the effectiveness, measure the tolerability, and do this with objective data rather than just asking the patient, how do you feel? Okay, so this is the 7-step plan that is currently recommended for the management of patients with pulmonary artery hypertension. So this you can find in the ESCRS guidelines of 2015, and it hasn't changed very much. This is the ESC guidelines for the determination of risk, and it's based on several signs which are clinical, a test like the 6-minute walk test, cardiopulmonary exercise testing, NT-proBNP levels, echocardiography or a cardiac MRI imaging, and hemodynamics. And based on these, and you can find this, I'm not going to take you through the details, you put a patient into either a low-risk category, an intermediate risk category, or a high-risk category. As mentioned earlier, if they're high risk, you move them to a PH specialized center. Otherwise, you can try initial management yourself. And this is based on what is the risk of mortality. Okay, so this is the one classification of determinants of risk parameters. This is another one. And the simplest one is the comparer risk stratification. And I think they all perform fairly well. So I tend to use this. It's based on the WHO functional class that I mentioned earlier, the 6-minute walk distance. And you can see that the intermediate risk comes at about 440 meters. As long as it's more than 440 meters, we're very happy. A BNP or NT-proBNP, not both. You can use either one of them. You can use the right atrial pressure, which is ideally done at right heart catheterization. As Dr. Raja has already told you, RHC is useful when you're dealing with group 1 pulmonary hypertension. In fact, these days, we wouldn't say it's useful. We'll believe it's essential to do it. calculate the cardiac index, again by doing the right heart catheterization, and look at the mixed venous oxygen at the center. So based on these, you can decide on what is the risk of the patient. And then you follow them up, as I said, very proactively and frequently, typically at 3 months, 6 months, and 12 months. And again, you look at the same things that we looked at to look at the risk stratification, but you also follow up with things like the kidney function tests, blood counts, liver function tests, thyroid functions, look at their chest X-ray and ECG, look at their pulmonary function, especially the DLCO, check their overnight oximetry, and always consider whether at some point, and most often patients with pulmonary hypertension do need palliative care. Okay, so this has to be done, and you take these assessments at 3 months, 6 months, and 12 months. The R's are the recommended, and the C's are to be considered. And I would say ideally every time consider these as options. For example, palliative care you'll consider at all stages. It's not an absolute requirement. Whereas assessing the functional class or the NT-proBNP and the 6-minute walk test are absolutely necessary every time. The echo has to be repeated, for example, at 6 and 12 months. You may not choose to do it at 3 months. You'll still be adjusting the medication. So you can do that at 3 months. Again, right heart catheterization, I think Dr. Raja has already taken you through this, is not required in every single patient at follow-up, but you have to do it at the beginning. So we have 3 pathways of therapy for pulmonary hypertension. The first is the nitric oxide pathway. The second is the prostacyclin pathway. And the third is the endothelin-1 pathway. Now, you have several of these which are new therapeutic strategies, but there are some which are already in use, such as the sildenafil, tadalafil, the prostanoids, ambrisentan, bosentan, and macitentan, which are all available in India. Only the prostaglandins are not easily available, but hope to get selexipag very soon. Now, how do these work? These work on certain key molecules. One is the cyclic GMP pathway. And what cyclic GMP does is it increases vasodilatation and reduces proliferation, because this is what underlies group 1 pulmonary hypertension. As you saw, there's vasoconstriction and there's proliferation of the endothelium and of the smooth muscle, narrowing the blood vessel. So we look to achieve the opposite with vasodilatation and proliferation. The same effect comes with cyclic AMP. After all, guanosine and adenosine are very similar. So GMP cyclic or cyclic AMP both produce vasodilatation and proliferation. So you want to increase the cyclic GMP by either increasing the production. Riociguat, for example, increases the production of works on soluble guanylate cyclase, which increases the conversion of GTP, triphosphate, to cyclic GMP. Similarly, nitric inhalation or using nitrites can have the same effect. Sildenafil and tadalafil, which are phosphodiesterase 5 inhibitors, work on reducing the breakdown of cyclic GMP to plain GMP, not the cyclic form. So they will produce vasodilatation and proliferation. You can get the same effect with the prostacyclins, which work on an IP receptor, the prostacyclin receptor, which works on adenylate cyclase, converting ATP to cyclic AMP, again achieving the same effect. And this is also achieved by selexipag, which is a direct IP stimulator. The endothelin pathway is slightly different. The endothelins, there are 2 endothelins which work on endothelin receptor A and B. Endothelin 1, when it works on endothelin A receptor, produces vasoconstriction and proliferation, as does ATP2. So the endothelin receptor antagonists block these receptors. These are bosentan and macitentan, and ambrisentan, which works only on ETA, endothelin A receptor. And they reverse the vasoconstriction and increased vasoproliferation that that endothelins do. And so ambrisentan, bosentan, and macitentan reduce vasoconstriction, in short, dilatation, and reduce proliferation so that we reduce the progression of the plexogenic arteriopathy that is seen in group 1 pulmonary hypertension. So 3 pathways working on the GMP pathway, producing more of cyclic GMP, working on the adenylate cyclase, producing more of cyclic AMP, and working on the endothelin receptors, blocking them, so the endothelin receptor antagonists or ERAs, and reducing the vasoconstriction, reducing the proliferation. So, in pulmonary hypertension, across all the groups, we have some well-defined treatments and some where the optimal treatment is not very clear. So, in the well-defined treatments, we have really only group 1 pulmonary hypertension, in that too, not all of them, and chronic thromboembolic pulmonary hypertension, which is either inoperable or operable. The optimal treatments in group 2, 3, and 5 are not very clear, except to treat the underlying conditions. And in isolated instances, you can use the pulmonary vasoactive medications, which I'll come to last of all. One of the newer drugs that we have, riociguat, binds to and directly stimulates soluble guanylate cyclase independent of nitric oxide. So you don't need the nitric oxide for this drug. Riociguat also facilitates the binding of any remaining endogenous nitric oxide to the same SGC molecule in patients with inoperable, persistent, or recurrent CTEPH or pulmonary hypertension. So it's important to recognize that this works not only in PAH, but is one of the few drugs that works in CTEPH. So as I said, what it does is it works on cyclic GMP and reduces fibrosis, reduces vasoconstriction, reduces proliferation, and also seems to reduce inflammation. So it works on all the targets that you can target in managing group 1 and group 4 pulmonary hypertension. So we have several drugs, as I said, and I'm not going to take you through too much of these, but it's important to learn the side effects of these drugs before you start using them, because these are not simple drugs. They all have their own complications. So it's extremely important that you learn how to manage patients with these drugs by understanding their use, their adverse effects, and very, very importantly, their drug interactions. Okay? So basic groups are PDE5 inhibitors, endothelin receptor antagonists, prostanoids, as I've already said, the SGC soluble guanylate cyclase stimulators, and finally, of course, the calcium channel blockers. The primary endpoint, when you look at riociguat, showed a very, very good improvement in terms of 6-minute walk distance. And you can see that those who received the placebo had an initial improvement, the placebo effect, plus all the other medications that you use. But there was a much bigger improvement, and this was sustained even over 12 weeks in patients with riociguat, whereas the placebo effect started to tail off. If you looked at secondary endpoints, which were the changes in the hemodynamic profile, you got a very significant reduction in the pulmonary vascular resistance. You got an improvement in the pro-NT-BNP, the mean pulmonary artery pressure, the cardiac index, the pulmonary capillary wedge pressure, and the cardiac output. And you'll recognize that many of these are those measures of risk that we spoke about earlier in the Compara risk score. So if you use riociguat or indeed any of the other pulmonary vasoactive medications, you expect the person's risk score to improve, which will translate into improved survival. Selexipag, again, I'm talking only about these few drugs which are new, so that you have, because we've had bosentan, ambrisentan, sildenafil, tadalafil for a very long time now, and I'm sure you've used them. The Griffin trial showed that selexipag, again, produced much better improvements in end events that were primary endpoints and secondary endpoints. You got many more patients without an event that suggested hospitalization or death when selexipag was used. And this difference started very early. Within a couple of months, you saw a separation of the survival curves. Similarly, with macitentan, the Seraphin study showed us that at any dose, macitentan, these two top lines performed better than placebo, but a dose of macitentan 10 mg was better than a dose of 3 mg. And that's why we use macitentan in a 10 mg once daily dose. And this was, again, something that happened very early. Within about a month, you started to see a difference in the survival curves, and it continued to improve over the 36 months of follow-up. And very interestingly, you see that these were patients who were probably milder, because in this group with macitentan, you found that they even were surviving well at 3 years, better than the 50% survival rate that we were talking about. This reflects two things. It reflects that we are picking these patients up early, which is really good. and we have more drugs to manage them apart from the pulmonary vasoactive drugs. So care has definitely improved, survival has improved, and it's due to a combination of early diagnosis and due to better drug availability and overall better care of these patients, including palliative care. Dr. Rajadhar has already told you about calcium channel blockers and how you do a vasoreactivity test. And these are the only patients who you should be using calcium channel blockers. Patients without an acute vasodilator response should not be treated with high-dose calcium channel blockers. And remember that even if there's an initial response, you must follow them up, because in many of them, the response to the calcium channel blockers is not sustained. And these are the dihydropyridine calcium channel blockers like nifedipine. The role of anticoagulants in pulmonary artery hypertension is somewhat controversial, because one of the things they've shown is with pulmonary hypertension, flow in the pulmonary vessels is sluggish, and this leads to in situ thrombosis. This has two consequences. Sometimes patients with idiopathic pulmonary hypertension and in situ thrombosis are confused as having CTEPH, and operating on these people is extremely dangerous. So one of the main tasks we have as part of a multidisciplinary group, which looks at chronic thromboembolic pulmonary hypertension and decides do they need surgery or some other form of treatment, is first to separate out CTEPH from the other causes of pulmonary hypertension. Anticoagulants therefore became a part of standard therapy because of the high rate of in situ thrombosis, and they may be of benefit with some evidence in observational studies, but this is a low level of evidence. And especially in conditions like scleroderma, there's even more controversy. So recent guidelines state that you can consider anticoagulation of these patients with warfarin or heparin. Obviously, in the long run, you'd prefer an oral anticoagulant, and warfarin is the only one tried. The newer drugs, the NOACs, have not been tried. So the treatment algorithm, as I already said, is if pulmonary hypertension is confirmed by an expert center, you go through with vasoreactivity testing, you risk stratify, decide on do they need initial monotherapy, or should you start straight away with oral combination therapy, and should you include, which is not yet available to us, an IV prostacyclin active agent, and if they are very, very sick, straight away you refer them for lung transplant evaluation. Remember, referral is not the same as listing for a lung transplant, but the evaluation and the preparation should start early, because it's very likely that these patients will end with needing lung transplant at some point. You reevaluated them at 3 to 6 months, and if the patient has now moved to a low-risk category or remains in a low-risk category, you continued the structured follow-up. If they have, however, moved into an intermediate or a high-risk strategy, you add on therapy. If they had started with monotherapy, you make it dual therapy. If they started with dual therapy combination, then you move to triple therapy. You reevaluate the same way. If they remain in intermediate risk or move to low risk, you continue the same treatment. Otherwise, you decide on moving them to maximal medical therapy, triple therapy, and then refer for lung transplant evaluation. So essentially, the steps to remember are once you've completed the acute vasoreactivity testing, risk stratify, decide on 1, 2, or 3 drugs to start with, which will include an IV prostacyclin, reevaluate every 3 months, assess the risk at every sitting, and then decide whether you want to add on therapy, continue the same therapy, or maximize the therapy, and at all stages, see if the patient will benefit from early referral for a lung transplant evaluation. So this is essentially the same thing, but you can consider right heart catheterization, echo, and CPET at any point when you want to escalate therapy. 2 stages that are very important is to decide if the patient has lung disease, and you want to decide if the patient has group 2 or group 3 pulmonary hypertension, and then decide in these cases whether you should put the patient on pulmonary vasoactive medication or not. And I'll come back to this later. And there's a variety of specific diagnostic tests that you must do, and Dr. Raja has already taken you through these. So, in a patient with proven chronic lung disease and pulmonary hypertension, first of all, you must look for the pulmonary hypertension. The symptoms overlap, and it's often easily missed, the presence of pulmonary hypertension. And when there is pulmonary hypertension, the prognosis is much worse in a person with chronic lung disease. So how do you decide this? If the patient has unexplained or disproportionate fatigue or dyspnea. So you see the patient seems to have, mild to moderate lung disease. For example, COPD, the spirometric classification is just, mild to moderate. FEV1 greater than 50 or 60%. And yet they're disproportionately fatigued. You do their CT scan and they don't seem to have too much lung disease. Interstitial lung disease, there's only some scattering of fibrosis seen, and yet this patient has severe breathlessness, very, very fatigued with exertion. Consider the possibility of pulmonary hypertension. When you examine them, are there already signs of right heart failure and allowed P2, despite the person not being hypoxic? Remember that in group 3 pulmonary hypertension, hypoxia underlies the genesis of the pulmonary hypertension. It is the etiology of the pulmonary hypertension. You go on to screen by looking at echo evidence, and then you decide, does the person have chronic lung disease with pulmonary hypertension? If the person has this, then you decide, are you dealing with out of proportion pulmonary hypertension? That means the person's pH is far more than you expect for their lung disease. And this you do by achieving their spirometry. And if the person has an FEV1 of greater than 60% or an ILD of greater than 70% FPC, you're probably dealing with out of proportion pulmonary hypertension. If it's less than this, you can reevaluate. You do a CT thorax or you have a CT thorax, the parenchymal changes are minimal, then you're probably dealing with out of proportion pulmonary hypertension. If there are extensive parenchymal changes, then you can say, okay, this is probably due to lung disease. If you still have a doubt, confirm with right heart catheterization. Ideally, you should do a cardiopulmonary exercise testing. And in out of proportion pulmonary hypertension, because the lungs are reasonably okay, it's the pulmonary hypertension that is a problem with its effects on the heart. They have exhausted circulatory reserve. And that will take a full class. We're not going to go into that. If, on the other hand, the lung disease is the main problem, then they'll have features of exhausted respiratory reserve, a little bit of exertion, and their CO2 starts to go up because they cannot hike their ventilation. So if this set of problems or findings is there, then this is likely to be chronic lung disease with group 1 pulmonary hypertension, out of proportion pulmonary hypertension, and you can either try pulmonary vasoactive medication yourself or refer to a center with PH expertise. If, however, the chronic lung disease is producing pulmonary hypertension, which is group 3, secondary to hypoxia, avoid PH therapy, treat the primary lung disease, and assess for long-term oxygen therapy, which will almost inevitably be necessary. And at all stages, whichever group you're treating, please institute cardiopulmonary rehabilitation and palliative care. If the patient progresses, have an end-of-life discussion with patient and family and decide clearly what you want to do. I'll spend the next few minutes talking about chronic thromboembolic pulmonary hypertension. And this is diagnosed, as Dr. Raja has already told you, when you perform a VQ scan, see there are segmental perfusion defects, or you've done a CT scan and you found that there are clear-cut features of chronic thromboembolic pulmonary hypertension. And I'll show you some of these if we have time. Okay, and at all patients, before you decide on an invasive therapy, please perform a right heart catheterization. So what happens in CTEPH really is that chronic emboli, the embolism doesn't get resolved as it usually does, but in anywhere from 3 to 10% of patients, we find that the clot gets organized, becomes fibrotic, causes stenosis of the blood vessels, narrowing of the cross-section of the pulmonary vascular bed. So there's chronic obstruction, but there's also small vessel disease, and that leads to affected right heart function. This may be spurred on by inflammation or infection, which is why we believe in India, where we have high levels of inflammation, CTEPH is more common than in the West, apart from a thrombotic tendency. And all this leads to residual pulmonary hypertension, goes on to develop arteriopathy, but also these days we know that there is venous and capillary disease. So more and more over time, some patients with CTEPH start behaving like group 1 pulmonary hypertension. And that's what we're seeing here. Changes in the blood vessel wall that are very similar to the muscularized arterioles that you see in PAH, capillary lesion like hemangiomatosis. You see venular changes like pulmonary veno-occlusive disease, apart from the thrombosis that you see. And this is very, very similar to what you see in patients with pulmonary artery hypertension in a few individuals. So if patients are not suitable for surgery, and I'll come to surgery later because that is an extremely important part of management, we have the option of balloon pulmonary angioplasty, and that works really well, as you can see, in terms of improving functional class pre and post BPA, in terms of improving the mean pulmonary artery pressure, in improving the pulmonary vascular resistance, and the cardiac index improves post BPA as compared to pre BPA. And basically what they do is they put in a balloon, dilate it, open up the obstructions, and they usually do this in several sittings, typically 4 or 5 sittings. You cannot do all sittings at once. It can lead to very dangerous rises in the pulmonary flow, causing what is called reperfusion pulmonary edema. And you can see very clearly NYHA classification improved in practically all patients except one, and the 6-minute walk distance improved in all the patients very, very significantly. IVC filters are often placed in patients with CTEPH, and centers differ in their practice. So now we're going to only talk about surgical treatment of patients with chronic thromboembolic pulmonary hypertension. The treatment of choice is pulmonary endarterectomy. But if a patient is not suitable for that, and the patient has very, very high pressures, you can do what is called an atrial septostomy, which is purely a palliative procedure, improve symptoms by shunting the blood from the right heart to the left side of the heart, because the pulmonary pressures exceed the systemic pressures. You can also do a port shunt, where you shunt the blood from the left pulmonary artery into the aorta. So the lower half of the body gets desaturated, whereas the upper half of the body, including the brain, doesn't suffer desaturation. Lung transplant is also very useful, and a lot of patients have a very high morbidity and mortality while on the waiting list for lung transplant, or indeed if they refuse pulmonary arterectomy, and I'll come back to this. So the preferred therapy for CTEPH, chronic thromboembolic pulmonary hypertension, is pulmonary endarterectomy, called PEA. Remember, it is an endarterectomy and not a thrombectomy or embolectomy, so don't call it those. Thrombectomy and then embolectomy are used for acute pulmonary embolism. In chronic thromboembolic pulmonary hypertension, we do an endarterectomy. It's always a bilateral procedure. You will never do a single side procedure. It's always done on cardiopulmonary bypass. This ensures cardiovascular stability, and it always is done with hypothermic total circulatory arrest. You stop the heart beating completely, you stop the cardiopulmonary bypass also temporarily, and then you restart it. And I'll go into a very quick description of what is actually done. The total circulatory arrest is necessary to ensure perfect visibility, because you've got to open the pulmonary arteries, and you've got to do this in short intermittent times with an arrest period of 5 to 15 minutes on each side. You cannot keep the person in total circulatory arrest beyond that length of time. How do you manage to keep the person alive without brain damage through total circulatory arrest? What you do is you wrap the head in a circulating cold water cooling blanket in preparation for this, and you cool the brain down. You also pump ice cold saline through them, and this is the close-up of the cooling head blanket. And the patient reaches temperatures rectal of about 20 degrees or so. Bladder and tympanic membrane is even lower because you're cooling the head down to 15 degrees. When you cool the brain down so much, you actually get into an isoelectric EEG. So the processed EEG is isoelectric before the arrest. Okay, so only when you got the brain level of activity down so much that there is virtually no electrical activity, that you can put the patient into total circulatory arrest. You can have many complications, both intraoperative and postoperative. And as I told you earlier, you can have persistent pulmonary hypertension, but you can also have a reperfusion pulmonary edema. And because of deep hypothermia, if you're not having a very skilled surgeon operating, they can end up with neurological damage. And of course, you cut open the artery. These are very thin arteries, and they've undergone vascular changes, including sometimes calcification. So sometimes they can rupture when blood flows through it again after you perfuse the patient. These are the kinds of operative specimens you get. Professor Jamieson is one of the pioneers in pulmonary endarterectomy. He's even designed the kind of surgical tools used for pulmonary endarterectomy. So we have 4 kinds. This is what is called type 1, where you have very large clots in the major blood vessels, the right and left pulmonary artery or their lobar branches. There is no major vessel thrombosis, but you're seeing clots in the lobar and segmental arteries. You can also see it in the subsegmental arteries and the segmental arteries, what is called group 3 PH. But this we try and identify and don't take them up for surgery. Professor Jamieson calls these trousers, not tails, because they literally are like your trousers. They stick to the sides of the vessel and they're very difficult to take out. So these patients are usually inoperable, and we manage them with either BPA or we manage them with pulmonary vasoactive medications. There's a very steep learning curve, which is why you must go to an expert center. These were our own problem. Our first 50 cases, there was a 31% mortality, very, very high. The next 50 cases, that came down to 14%. The next 100 cases was down to 8%. Not last year. This is when I made these slides. It was about 1.5% to 2%. Now it is about 4% because we're taking up more advanced cases. At about year 3, we learned that many of these patients were not having good outcomes. We cut down the more serious cases. Now we're taking them up with a mortality rate of about 4 to 4.5%, which is world standard. And all countries have gone through this kind of learning curve. And this is what we found in the UK, Papworth Hospital, and Professor Jamison's group, the UC San Diego group. But what you can see from the Papworth experience, and ours is similar, is a significant improvement in functional class. These were patients before their pulmonary endarterectomy. At 3 months, a lot have already moved into class 1 symptoms, virtually normal, and most of the remaining, over 80%, are either in class 1 or class 2. There's practically nobody with class 4. And by 12 months, you again have probably more than 85% with class 1 and 2 symptoms, and very few, about 15%, with class 3 symptoms. Okay, so surgery has extremely good outcomes when it comes to chronic thromboembolic pulmonary hypertension. When do you use medical therapy? When a patient is inoperable because of class 4 disease, the type that I mentioned, the type 4, when you have small vessel vasculopathy, and they have too many comorbidities that contraindicate surgery. So we don't think the patient has a good chance of coming out of surgery. Those who, even after pulmonary endarterectomy, and this is about 10 to 15%, as you just saw, have significant residual pH. And when you want to do it as a bridge to surgery, you want the patient to be slightly better. Sometimes they come to you with class 4 symptoms, virtually unable to even lie down, they can't move around. Then you start them on treatment, bring down the pressures a bit, get them a little less symptomatic, and then take them up for surgery. But many surgeons don't like this because it makes the clot more friable. Medications that you can use include all these, but riociguat is definitely the treatment of choice. There's some evidence that macitentan may also work. As I said, the balloon pulmonary angioplasty is very useful and is used for inoperable cases or those who refuse surgery. This is fairly common in Japan because Japanese patients culturally don't like to have a sternotomy wound. They don't like to have their chest cut open. So the treatment, therefore, for CTEPH is continue lifelong anticoagulation, get them assessed for operability by a CTEPH team. If they're operable, definitely pulmonary endarterectomy is the treatment of choice. If they're non-operable, always get a second opinion by an experienced center, because very experienced centers will take up patients whom others refuse. If they still refuse it, target them for medical therapy, consider treating them if they also have symptomatic pulmonary hypertension despite the surgery, and consider whether you want to refer for lung transplant or do a balloon pulmonary angioplasty. Surgery is clearly the first choice. So you have here a group where pulmonary endarterectomy was done, showing you very good outcomes even at 20 years, unlike patients who did not have or refused a pulmonary endarterectomy, where mortality was very high. Survival at 5 years to 10 years was between 75% and 50%. You can also do lung transplant for pulmonary hypertension, and this is not only CTEPH, this is any form of pulmonary hypertension. And you can see that it does improve the outcomes somewhat, and you can see that it depends on the kind of underlying etiology. CTEPH patients do best of all, even if they have undergone lung transplant, compared to other groups who do poorly. Idiopathic pulmonary artery hypertension, we do it very late, has a poor outcome. Bilateral lung transplants have better outcomes than a heart lung transplant. And you can see that over time, the survivals have improved a little from the early 97 to 2004 as compared to a cohort which was seen in 2005, 2010. This was a single center experience, the Toronto Center, where I spent a small amount of time, an excellent center, and pioneers in lung transplant. But this is the heartening slide I want to leave you with. I already spoke to you about the NIH survival curves and the French survival curves and the REVEAL registry. This is from Okayama. He looked at patients he had treated between 1998 onwards, and the survival in patients with heritable pulmonary artery hypertension, one of the subgroups of group 1 pulmonary hypertension, much better survival. In fact, you can see that at 5 years, more than 95% of his patients are surviving. This tells you the long way we have come from 1981 to 1985, improved between 2002 to 2003, subsequently 2006 to 2010, and even better survival. And over time, with a very specialized center, you can get excellent outcomes in patients with idiopathic pulmonary artery hypertension or hereditary pulmonary hypertension. So we can see light at the end of the tunnel, but we have promises to keep for our patients and miles to go before we or they sleep. So I'll leave you with a few key messages. Pulmonary hypertension is a pathophysiological state characterized by an increased pulmonary artery pressure and increased pulmonary vascular resistance. And both features are important. Pulmonary artery pressure and pulmonary vascular resistance, as measured, as Dr. Raja told you, by the pulmonary capillary wedge pressure, also known as the pulmonary artery occlusion pressure. It needs to be less than 15, and the pulmonary artery pressure needs to be more than 20 millimeters of mercury, mean PA, pulmonary artery pressure. The group of pulmonary hypertension and the etiology determine the treatment. The treatment of pulmonary artery hypertension should follow a stepped care approach. Survival in pulmonary artery hypertension is improving dramatically, as I've just shown you. The treatment of chronic thromboembolic pulmonary hypertension, or CTEPH, is ideally surgical, and the surgery is a pulmonary endarterectomy. Other groups will receive pulmonary artery hypertension medications only if the pH is disproportionate to the physical findings for that group. So, is the person's mean pulmonary artery pressure more than 20 millimeters of mercury? Is the pulmonary vascular resistance more than 3 Wood units? Is the person having pre-capillary pulmonary hypertension, which is a pulmonary artery occlusion pressure or a pulmonary capillary wedge pressure less than 15 millimeters of mercury? What is the group of pulmonary hypertension and what is the exact etiology? Then you decide, am I going to put the patient on a stepped care approach and follow them up very, very carefully every 3 to 6 months and adjust their treatment very, very frequently? Survival will then improve dramatically. First of all, rule out treatable causes like chronic thromboembolic pulmonary hypertension. If it is lung disease and hypoxia, proportionate pulmonary hypertension, treat them with long-term oxygen therapy and treat the underlying lung disease. If it is group 2, treat the heart disease with appropriate medication. Do not use pulmonary artery hypertensive medication, group 1 medication. But if it is disproportionate, use pH medication. And reassure your patients that the poor survival they will read about on the internet, Googling it, is much better now, and you can offer them better quality of life and better survival. Thank you so much.
So that was excellent, Murali. And I don't know whether Raja has already joined or not. Raja, are you there? In time?
Yes, sir.
Okay.
Listening to Murli all these files, absolutely.
So really it was excellent. Almost I was going through a sweet dream at this age, listening, and the very positive note that Murali ended actually. It was really very fine. Now, we have some questions, but before that, I have one question to Murali. Murali, are you there?
Yes, sir. Very much.
What is the percentage of CTPA that you get among the total cases of pulmonary hypertension? What is the percentage that is chronic thromboembolic? How many do you get?
So it all depends, sir. Ours is a referral center, so we have a disproportionately high number.
Exactly.
The problem is, if you look at the general population, I would think that about 5% may probably be CTEPH. A lot of it is missed, and that's the tragedy. And we must look for it in unlikely places. For example, I think Zarir has shown, and many other people have shown, Zarir Udwadia, that about 9 to 10% of patients who come in with what looks like an acute exacerbation of COPD actually have an acute pulmonary embolism. And that's a huge number of people. If you look at 9 to 10% of acute exacerbation of COPD, whether it's the cause for the acute exacerbation or is a complication that occurs during their acute exacerbation is not clear. And if you remember that about 3 to 10% of patients with acute PE go on to develop CTEPH, that's a small percentage, but in terms of numbers, it's a huge number. So we should actually be finding a lot more than we're finding. And I can tell you, since we've started talking about it in the last 10 years, we're getting a lot more referrals from all over the country because people are picking it up very well.
Exactly. So it's a referral center and awareness is increasing. So you'll get more cases. Maybe at your center, there may be disproportionately more cases of CTEPH compared to others. Now, Raja, so what is your exact comment? This is a class actually. So you have to show in the message. This new definition for PAH, bringing down this 25 to 21. So what is your exact message on this?
So, sir, I think the fact that the mean pressure has come down to 20 does not really translate into any effect on the treatment protocol we have today. Nor do we know enough to say that the prognostication of PAH is actually going to change because the pressure has come down. I think what we wait is trials which will look at this lowered pressure and the effect of medications on this lowered pressure as we go forward. So mercury along with a 3 Woods unit pressure pulmonary artery. So that's what we are looking at. And after we have done the trials, I think it will have an effect. But I think it's good to be aware that the pressure threshold is 20 millimeters of mercury. That's what we need to be aware about.
I have a feeling. Yes,
can I just add that this 20 millimeters of mercury, Raja spoke about this, but I want to highlight this because we're talking to a bunch of pulmonologists. 20 millimeters seems to be a more important cutoff, especially in lung disease. Long time ago, people like Weizenblum and Shao showed that once it crossed 20 and you had lung disease, outcomes were much worse. You didn't have to wait for 25 or 30 or 35. And patients with a 25 to 35 mean pulmonary artery pressure actually had much worse outcomes. So as pulmonologists, we must remember, but I would completely agree with Raja, that's not a time to keep telling people you have PAH because they'll panic. And 2, we must also remember that that is not a time but for you to start them on treatment, but it's a time for you to evaluate. Is there any reason the pulmonary pressure is so high? What is happening to the nocturnal oxygen? Should we be aware of a second problem? Like, is this a patient having an overlap of OSA with COPD or something like that, which makes you aware that their pulmonary pressures are rising more rapidly than expected? So follow them up, essentially, is the message.
So it's
I think this is even more
raising the awareness actually for earlier diagnosis. So don't wait for 25, 20, you start, you look for the causes. So it is probably bringing down the threshold for more early diagnosis so that we can go for remedies.
I was going to say, sir, you said something which I think is very important, that there are certain diseases like CTD-ILD, especially scleroderma, where this cutoff is probably much more important. For in scleroderma, if you reach 20, it probably has far more significance as compared to someone who's got COPD and has a pulmonary artery pressure, mean pulmonary artery pressure of 20 millimeters of mercury. So the disease process, I think, is also important.
Exactly. Okay. The next one. Now, Murali. So what is your comment about this late diagnosis message for the students?
So late diagnosis, late beginning treatment, more mortality. The earlier you make the diagnosis, the better are the outcomes. So once you have an early diagnosis, there are 2 factors operating. And I think this is important for students to know. As our recognition of the problem and our ability to pick it up, as Raja was saying, with early echo improves, and greater awareness that, the echo technician and the cardiologist should look at the right side of the heart also improves, you make an early diagnosis. So this is sometimes called lead time bias. You make the diagnosis early, so it looks like the survival is longer. But even if you eliminate the lead time bias, you will still get a better survival when you start treatment early and move into combination treatment early.
Okay, now both of you, do you think somebody may think a little biased when you insist that much on right heart catheterization, whether echo as screening method is good enough to screen most of the patients? Both Murali and Raja, one by one.
Raja, you want to go first?
I'll go first, Murali. So I think echo is a screening method, like you said, sir. I don't think there's any dispute about it. Talking about a right heart cath in the perspective of offering treatment. And I think this habit of prescribing drugs like sildenafil, busentan, which are easily available and sort of cheap by comparison in India, just based on echo, has probably resulted in more harm than good. And I think rather than depending on echo to prescribe these drugs, if we try and build up centers of excellence where we try and make sure right heart catheter gets done. I mean, there's so many angiographies that get done in this country and they get done willy-nilly. I don't think developing right heart catheter service in this country is going to be that challenging. And I think the focus should be on that rather than saying echo is enough to actually prescribe drugs for pulmonary hypertension.
Okay, Murali.
I completely agree with Raja. I don't think there's much to add to that, except to say that right heart catheterization is not as dangerous as people used to think it was. It's far, far safer, has mortality rates roughly in the range of our more complicated bronchoscopies. So there's no harm in getting it done. Remember that when you see an echo, it must always be correlated with the clinical features. So you must have a high clinical suspicion always. And Raja has beautifully brought out what the ESC has said. When you will say this is low risk, intermediate risk, and high risk, and only in the intermediate and high risk, you will pursue it. If the person is low risk, then I think I would ignore the echo and just repeat it after 3 months.
Okay. This one. Okay, again, start from Raja. So what is your comment exactly? Again, the message for the students, overlap. You have shown one case, Raja.
Sure.
It comes to overlap, but is it that you want the primary condition first before considering the overlapping comorbidities when you are going to deal?
I think what Murali said actually holds true in answering the question. I think it's important to have a good history and clinical examination and correlate with the echo. I think even when there are multiple contributory factors, if you do a good history, you will know what is the factor which is driving the pulmonary hypertension in that particular individual. I mean, the history, the case I presented was more for demonstration rather than being an actual case. But I think whether it's the COPD or the obstructive sleep apnea, or whether it's the left heart disease which is causing the right heart disease, or whether it's a bit of everything, becomes apparent when you take a good history. And I don't think the treatment decision would actually be hampered a lot if you take a good history and then decide about prescribing drugs in an individual. I don't think it matters to that much of an extent, but overlaps do happen. And I think it's important to try and bring out these overlaps when you see individual patients.
But I think still you concentrate on the primary condition, then you think of the overlap comorbidities, isn't it? The primary condition needs to be concentrated.
Sure, absolutely. I think that's where the history comes in. I think the primary condition becomes difficult to identify, sir, when you're trying to sort of, unless you take a good history, you wouldn't know what's actually driving the pulmonary hypertension, what's the primary condition, and that's where the history comes in.
Really, anything?
No, absolutely. I mean, completely agree with Raja on that. There are rare cases where you will not be able to tease out the differences. But in that case, you will treat them for everything. You will treat them for the hypoxia, for example, in group 1. COPD patients, for example, one of the big problems is we know that a significant number have coronary artery disease, they have hypertension, a lot of cardiac comorbidities. So you look carefully, very often you will find that there's a significant element of diastolic dysfunction, a very large left atrium, a left atrial diameter on echo of say 44. I saw one a couple of days ago with a LA diameter of 48 millimeters of mercury. That tells you that the LA is really large. That doesn't happen because of the pulmonary hypertension. It doesn't happen because of COPD. There must be significant heart disease. So you're dealing with left heart disease as part of the COPD comorbidities, and you need to tackle that just as much as you tackle the COPD and the hypoxia that goes with it. So it is, as Raja was saying, history, and looking at all the various contributory factors.
So see what effect you have made to the students, both of you. Somebody is asking, is it possible to go through echo for all cases of breathlessness to look for pulmonary hypertension?
So I think
Yes.
fair point, sir. I think in today's day and age, echo should actually be a basic investigation. To be honest, if this persistent breathlessness which brings the patient to a hospital, an echo probably becomes a compulsory tool in trying to diagnose the cause of breathlessness, like a chest X-ray or a spirometry is a basic investigation to try and get to the bottom of breathlessness. So I think it's a basic test. And if this persistent breathlessness, which the patient is distressed about, do get an echocardiogram. But again, I think a history and examination of the patient is as important, and correlate the history and examination findings with the echo is what we would all say.
So Raja, we have to temper down a little that yes, you have to document the breathlessness and then you have to look for the other causes. And if you cannot exclude, then of course, echo is one of the important measurements. There is no doubt about it. But that does not mean that even echo needs a wise, intelligent application, isn't it? It is not a blind examination that anybody can go through. And for echo also, one has to know what he is looking for. Otherwise, he may miss. I have seen cases where they have been missed because echocardiography has done just as a routine measure.
I mean, okay. I think Murli will not sort of suffer from this, but sir, you and I have. I think the operator who's doing the echo is the most important tool there, because it's an operator-driven test. And unless you have someone who can look at the right heart, the importance of echo for people like ourselves who are pulmonologists gets lost. And
I try to sit with them, actually. And at least if not, then I have to communicate with them previously, before doing the echo, that we have to look for this. Okay. Murali, by the way, what is your experience of Rheosyogat with PSS? How it is working in PSS?
Reasonably well, sir. We use it in a few patients. You have to be very cautious when you're using it, because there's an increased risk of pulmonary hemorrhage when you're using Rheosyogat. And you've got to slowly increase the dose. You start at 0.5 3 times, and you can take it up to 2.5 3 times. But you've got to do this slowly and in steps with careful monitoring. Otherwise, it can lead to a sudden drop in pressure. It can lead to a lot of dizziness. It can really ruin the person's quality of life if you're not careful about it. But it's useful. It's useful in all forms, but systemic sclerosis associated PH definitely has been used. But you don't need to go for Rheosyogat. They all work reasonably well.
It looks like a wonder drug. It works in all the 4 compartments: inflammation, fibrosis, proliferation. And are there new congeners coming?
Not. There are a few which are in trial, but they have not been released, not been licensed yet.
Okay. So now this is what Murali wants to ask, but again, we will not get answers from them. We have to give your own answers. Murali, here you have done one thing. You have kept all of the above. So we don't have any choice here. You see, the most important factor in determining the outcome of PH is functional class, etiology, 6-minute walk distance, and all of the above. So we don't have a choice. We are putting all of the above.
Yes, sir. All of the above.
But I still feel practically there was this hidden confusion between pulmonary arterial hypertension versus pulmonary hypertension in the mindset of the students. That was the hidden confusion, I think, over the last 15 to 20 years. So now that it has been clarified, I think it has made a great progress in understanding pulmonary hypertension. Okay. So Murali, why have you quoted bradykinin pathway? Something in your mind?
No. Just there's been a lot of talk about bradykinin pathway in the COVID era.
Yes.
So I needed to put in one to cause some confusion. So this is an accept thing. So
no, something subconscious bradykinin. Why?
So bradykinin is very important in the vascular system, we know.
Yes.
So that is why I put it in, but it's not been shown to. We still don't have any drugs in that pathway yet.
Okay.
Sir, can I ask a question to Murli in the meantime?
Please.
So Murli, the fact that I think the prostacyclin analogs are going out of patent next year, and we'll probably have prostacyclin analogs in this country. Do you think that's going to make a huge difference to the management of the patients that you see in a tertiary care center? Or do you think that's just going to be a small add-on to the armamentarium of drugs we have already?
The problem is most of the prostanoids are given as parenteral preparations. So most of them are given by a pump, or you've got to take repeated injections. Only a couple, there's one available orally, and of course, there is CTEPH, which works on the same pathway. And I'm really hoping, we've had discussions about this for the last year and a half. Then COVID, interrupted us rudely, so we haven't got it. I think CTEPH is actually going to be the game changer and not the intravenous prostacyclins. The pump is going to be expensive, difficult to use. So I don't see the others being all that useful. Beraprost oral and CTEPH oral are probably going to make the difference.
And the nebulized alloprost, do you think that's going to be?
Yes, but that is going to be a little more difficult because it's got to be taken regularly, frequently. But, we have patients who insist on using nebulized medication for their obstructive airways disease, so why not?
Okay. There is someone who is asking, Murali, I think, what is the first drug to start, then double with what and triple with what? This is because of the net, internet, Google. So what drug first to start with, then double with what, then triple with what, Murali?
So you can either
total message.
Yes, sir. You have two classes that are available to us now. So you can either start with the nitric oxide pathway. That is, usually we start with sildenafil or tadalafil. Very often we start with low dose sildenafil, escalate it, then we add on tadalafil, substitute with tadalafil if necessary. And then, of course, we would add on the ambrisentan or bosentan, one of those drugs. If a person has liver disease, for example, and that's why I emphasize, be aware of the adverse effects, be aware of the interactions. You don't use bosentan in somebody with liver disease because it's known to be liver toxic in a few. So I would straight away start with ambrisentan. So the usual thing is to go from a PDE5 inhibitor and then add on a ERA. Once the CTEPH becomes available, that will be the third drug to add on. At the moment, we don't have a third drug, except in a few very, very rich individuals who can afford to import the prostacyclins. But that's really a very difficult thing to do.
Now, what's your take on this? To begin with the combination therapy, say tadalafil with ambrisentan, what's your take on that?
In people, as I said, with intermediate or high risk, for 1 year, the combination straight away, sir. But what I meant was, you usually use them one at a time. You don't wait for 3 months to add on the second drug. You start the first drug, see how they tolerate it. So you know if there's a drug causing a problem. Then within a couple of weeks, you introduce the second drug, once you're sure the first drug is tolerated. So really, you're starting with combination of 2 drugs.
Coming back to a very basic. So in a case of COPD with pulmonary hypertension, do you think home oxygen is the basic ingredient before starting any drug?
Absolutely. Absolutely. Especially if they have. Now, the studies don't support LTOT at night, long-term oxygen therapy at night alone for patients who don't have daytime hypoxia. But what we have found is when you start such patients on oxygen, their pulmonary hypertension doesn't seem to get worse as fast. My own belief is that if a person is hypoxic at night, on an individual basis, I would still, first start with oxygen and see what's happening to their pulmonary pressures, their quality of life, their 6-minute walk distance. If that is improving, I'll keep them on nocturnal oxygen, even if not daytime oxygen.
And is it a routine to go for sleep study in all the cases? Is it routine diagnostic workup in your center?
Not all, sir. Only when we haven't found an adequate explanation. But I think it's worth doing an overnight oximetry. You don't do a full-blown sleep study. You just do an overnight oximetry. And there are many people who will do that for you.
Okay, now you have spoke very passionately about endarterectomy. So what is your message from this slide? What do you want to convey?
So the ideal treatment is pulmonary endarterectomy. If they don't work, then you can try, or the patient is unwilling or unable to go it. So the person is inoperable or refuses operation, then you go to the balloon pulmonary angioplasty for distal disease, or you can try medical treatment. and it's not called a thrombectomy or embolectomy.
Okay, so we have covered a long way and a long topic. So I fully agree with you now. This should have been taken 4 classes, each 1 hour. But you have done excellent job by confining it to this space and time. And it has been a really very hardening experience. As I said, it was almost a pleasant dream for me. So Murali, before we end, what is your parting message to the students on approach to pulmonary hypertension? Your part is management.
So the pulmonary hypertension in all the areas we spoke about is more common than we think it is. Please look for it because it determines your patient's survival in the long term and improves their quality of life if you pick it up and treat it appropriately.
Is there another question? Okay, this question comes now. How long it takes to show the results after oral drugs in pulmonary hypertension? What is the time? I think you said Yoshiogat looks very early results, something. Yes, Murali.
So it's about 3 months that you expect their symptoms improve, but I would not do that evaluation for at least 3 months because there are a lot of things settling down. And ideally, you wait about 3 months before introducing a second drug, maybe even 6 months. So give it a little time because there's a lot of slow adjustments to treatment, and you have to hike the dose in some of them gradually.
6 months is a good time. Raja?
6 months is a very good time, sir. Yeah.
Parting message to the students.
So I think my parting message overlaps with what Murli said. I think it's important. So I go back to the question that one of our audience asked about breathlessness. So in examining a patient who is breathless and taking history, please take a detailed one and do an echo as a screening test early if suggested by means of your history and your clinical examination. And if you manage to diagnose hypertension early with a screening echo on the basis of a history and signs, you're probably going to improve survival of your patient significantly by doing the screening test at the right time. I think that's probably and I think group 3 pulmonary hypertension, which is what we are concerned about, I think it's important to see these patients of COPD, see these patients of ILD, and think about pulmonary hypertension as an ancillary feature of group 3 pulmonary hypertension, which we often do in clinical practice. And that's something very important for the students to think of.
And do both of you agree with me with my message that pulmonologists should have a first-hand experience of doing echocardiography themselves?
Absolutely, sir. Yeah.
And also find a good echocardiographer to do it with you, sir. I think that's also equally important.
Actually, it is a job to be done by pulmonologists themselves. Cardiologists have a lot to do with the left heart. Let them do that. Let us concentrate on the right heart. This is our domain. We should be more conversant, actually, to even interpretation of the findings. Okay. So
can I just add?
Yes, Murali, both of you.
Can I just add? I mean, I think you mentioned this in the beginning, but I think Raja is one of the finest explainers. I'm supposed to, know a lot about pulmonary hypertension, but the way he explains it, I think is brilliant. Raja, hats off to you. You're one of the finest orators, explainers of concepts, making them simple for all of us. Thank you.
I said that I never say it in his presence, Murali. I always say it in his absence.
No, Murali, thank you very much. And I was going to say that I think you guys need to come up with a system where we train people for right heart catheterization, people to set up pulmonary hypertension clinics in this country, tertiary care centers. You lead. And I think we need more centers like yours in trying to treat this disease and set up centers catheterizations throughout the country.
We work with you, Raja. You told me this before. Then COVID rudely interrupted us. We will take it up again as soon as we're over this hump.
So before finishing, the next class is on 29th October, eosinophilic spectrum of lung diseases. Thanks everybody for this very fine evening. Thanks Raja, Murali, and our sponsor, the Lupin team, who have made this possible. It was really a great enjoyment. Thank you all and have a good time.
Thank you.